I'd like to welcome you to the New Options for Lung Cancer Therapies talk. Our presenter today is a medical oncologist and clinical researcher in thoracic oncology at Stanford. In addition, he is assistant professor of medicine oncology at the Stanford University Medical Center. Please welcome Dr. Joan Neal.
Thank you, Ellen. And thank you, everybody, for coming. It looks like we got almost the right number of seats here, and I think we have 5 people on the web, so fantastic turnout. I'm going to assume everybody either knows somebody who's getting treatment for lung cancer at Stanford or is involved in the clinical trials effort. If you want to identify yourselves as not one of those people, you're welcome to volunteer that information. But yes.
I'm Bindu. I'm a clinic manager from oncology pharmacy at Walgreens.
Okay. The Walgreens clinic pharmacy. That's great. Anybody else who has a role and a perspective? Because I'd like to address everybody's perspectives in this that they want to volunteer.
I have a mother-in-law who was just diagnosed with stage 4 lung cancer, and she had small cell in Florida. She had tried to enter into a clinical trial, but she had the wrong type of cancer. So I went through enrolling in a clinical trial and then being taken off the clinical trial.
Oh my, yeah, it's a lot of effort. I sometimes describe it like the checklist that pilots have in the front of the airplane that they're trying to go through and make sure that everything is perfect. But then you can find one thing and you get stuck right there. So sorry to hear that. Has she been out here or not been out here? Okay, all right. Any other perspectives anybody wants to share? That's fine. Okay. Well, let's get going. So when we think about what's new in lung cancer, part of the question is how do you frame the word new? Is new since lung cancer was first identified 100 years ago by chest radiographs, or is new since we first got effective platinum-based chemotherapies over the last 20 years? Or in the last 10 years when we got targeted therapies, or the last 2 years when we got immunotherapies? All of these things are new and exciting. So I'll go through those developments as the core of the talk. And then we'll also talk about what's new, i.e. all these clinical trials and things that we think about. And that's where we can have a little more free structure, because literally for every one drug that we talk about that's gotten approval, there have probably been hundreds of clinical trials of similar things or that didn't work, that were shots on goal, every bit as important as every drug that was approved, every bit that. So we'll focus on the core things that have been approved and can touch on the elements of why they were approved if we want. And I'm happy to spend more time on any particular drug or any particular therapy. We don't have to follow the structure, but it's a pretty generic structure. And then we can talk about what's new and exciting and out there and where things might go. But we're hopeful. I mean, we've had tremendous developments over the last 10 and 20 years and the last couple of years, and the pace is accelerating. So it's great. So first, I thought I'd start off by introducing the thoracic oncology medical oncologists here at Stanford. I wasn't trying to exclude our awesome nurse practitioners or our thoracic surgeons or radiation oncologists or the other people behind the scenes that you don't meet, like our pathologists and radiation oncologists, or the people that sometimes interact, like pulmonary team and interventional radiology team. But in lung cancer, we interact with a lot of people in the hospital. And when I stand up here, I can't take credit for developing any of these individual drugs. That's done as a team. And the care of cancer is also done as a team. Our research coordinators, many of whom are here and strongly support us, we couldn't even do a bit of what we do in terms of making things better in lung cancer without strong support and talented research coordinators. So we're incredibly lucky to have so many resources, so many people here. And these are just kind of the docs who get all the credit of being the doctor, but everybody else supports us, and we couldn't do it without you. So we'll start off with cancer statistics. First of all, why do we care about lung cancer? Well, if you have or know somebody who has lung cancer, obviously that's the most important thing. But lung cancer is actually remarkably common. So lung cancer in both men and women is the number 2 in terms of new cancers. And what's number 1 in men is prostate cancer, which often is diagnosed as a relatively small, indolent, locally treated cancer. Or breast cancer in women is number 1, often diagnosed again as small nodules, whereas lung cancer is still the number 2 in terms of incidence. That's the number of cases total in the United States among both men and women. But when we look at the estimated deaths of lung cancer, it outshadows prostate cancer by nearly 3 to 1 in men, and breast cancer by almost double the number of deaths in breast cancer. So really, the focus on lung cancer, and a lot of the success that we've had in having so many resources from clinical trials and new drug development and everything is because it is, unfortunately, a common disease. And among cancers, it's one of the bigger killers. Now, we're trying to change that. We're trying to diagnose it in the earlier stages. There's a little bit of CT screening that's gaining traction, but that's for people who have smoking-associated lung cancer. And as we know, many people don't have smoking-associated lung cancer. They haven't smoked. It's not really secondhand smoke or anything else. We can talk about what it might be, but it's really nothing other than what causes colon cancer and breast cancer, which we don't really know. It's kind of genes, bad luck, environment, who knows? We'll go through staging just because I feel like it's important to understand where lung cancer is and how these different stages factor in. So stages, what we use those as in the clinical setting is to kind of put patients into treatment-related groups and prognostic-related groups. So a stage, once a patient's staged, it connotates sort of an average chance of cure or average chance of survival, but that's like the middle number. It's not the range. It doesn't convey the range. And it also conveys what are the treatments that we should be thinking about. Should we be thinking about cutting it out with aggressive surgery, or should we be thinking about controlling it wherever it might or might not be? So stage 1 lung cancer is basically a small nodule in the lung. Stage 1B tends to be a little bit larger. Stage 1 is treated with surgery, although increasingly the radiation oncologists are able to focus radiation so tightly and so precisely that they say they can hit and kill these nearly as efficiently as surgeons can take them out of the body. So radiation is gaining traction in terms of a local treatment for very small nodules, but it requires you to know exactly where the cancer is. And radiation is a very different game if you radiate just in case cancer somewhere, because you have to give the same dose, a very high dose. So focal radiation is moving into the surgical realm, and surgical techniques are getting less and less invasive all the time also. So both are getting safer in terms of treatment of early stage disease. For early stage lung cancer, we just treat it, but it still has about a 30% chance of coming back even when it's a little nodule. A 30% chance of coming back, which means biologically, inherently, lung cancer is one of these types of tumors that just figures out how to spread. It just does. Stage 2 is often a little bit bigger tumor or close to the outside of the lung. And sometimes we will give these larger tumors, 4 centimeters and over, we'll give patients chemotherapy after they've had surgery to try and decrease the chance of the tumor coming back afterward. Stage 2, it's moved to lymph nodes. So the place the cancer cells move first is from the tumor through little lymph nodes in the lung and then move up to the local lymph nodes, which are on the same side in the lung. And these are almost always treated with chemotherapy after surgery as kind of an insurance, just in case there are cells floating around. Stage 3A and stage 3B start to get a little complicated because these are tumors that have now spread to lymph nodes, maybe in the lung, but also ones right in the middle of the chest. So on the side of the windpipe, either the same side as the tumor in stage 3A or the opposite side lymph nodes in stage 3B. And the major differences between these is a surgeon can theoretically go in here and take out some of these lymph nodes and take it out from the same side. But during a surgery, patients are ventilated on this lung, so you can't really go over to the other side and mess around with it. So stage 3A we'll consider surgery for. Stage 3B usually you use chemotherapy together with high doses of radiation that can kill the tumor in all the areas that we see. And then unfortunately, about half of lung cancer is diagnosed in the stage 4 setting. It just is what it is. There aren't receptors for nerves in the middle of the lungs, so it takes other symptoms of metastatic disease to diagnose stage 4 lung cancer. And these are patients with stage 4 treated mostly with systemic therapies, because while it's spread to potentially lungs, adrenal glands, lymph nodes, bone, brain, these are all common sites of spread, it's often in more places than we can just see it. So we can't easily use surgery or radiation to target everything and get it all. Whereas systemic treatments work everywhere. And that's why we use systemic therapies to control what we see and what we don't see. So this talk, I'm going to go through chemotherapies, and then I'm going to go through targeted therapies, and not everything, and then I'm going to go through immune therapies as kind of separate pillars of development of non-small cell lung cancer. So the chemotherapies, the timeline, it basically goes back to about 1995. And cisplatin and carboplatin following it have been around as mainstays of lung cancer treatment since the late 80s, the 90s. But were the first drugs to really show that they shrunk lung cancer. So surprisingly, I hear stories about 20, 30 years ago, patients were diagnosed with stage 4 lung cancer, and basically the best treatment to offer was symptom-based care. Sometimes people were offered chemotherapy, but the common perception was the chemotherapy was really toxic and minimally effective. So the old drugs didn't work very well in lung cancer. And cisplatin, or the platinum drugs, were the first of a class that was better tolerated than stuff that had come before, and also more effective in shrinking the cancer, so that it started to shift the balance of patients saying, well, you know, the side effects of treatment are actually worse than the side effects of the cancer. And also in a big study looking at patients who got platinum or didn't get platinum, it looked like patients who got the platinum therapies in general lived about twice as long as the patients who didn't. So that was the first time there was really a jump and said treatment of any kind is worth it. And when we think about where we are today, that's just shocking, right? That as recently as 20 years ago, 20 to 25 years ago, people said, is it worth it to treat at all? And here we are. So that's the perspective that I have in the amazing, like, what's new? Everything in the last 20 years is basically new because we started from a place of not treating. And so what are the developments that we had? Well, there were the platinum-based therapies back in the 90s, and then a number of drugs that were all sequentially more tolerable or more effective than the ones that had come before started to come out. So platinum-based therapies were often used with an older drug, considered new at the time, called vinorelbine. We almost never use vinorelbine anymore, but it's still an effective drug in lung cancer. It just has a fair amount of toxicity. Numbness and tingling, hair loss, things like that, irritants when it goes into the veins. So newer treatments have gotten more tolerable. And the taxanes like docetaxel or paclitaxel. Docetaxel was the first drug to ever get second-line approval in non-small cell lung cancer. So we started for a place of, is it worth giving first-line treatment? And that actually got FDA approval for, you should give first-line, of course, and you have to test what should you give second. And it was docetaxel versus placebo, or best supportive care, which approved docetaxel in this setting. Erlotinib too. Erlotinib's better known as Tarceva, and it's an EGFR inhibitor, and now it's best known for its role in treating a very specific type of lung cancer, EGFR mutant, that we'll touch on. But it was actually approved and tested originally for all lung cancer, regardless of type, regardless of histology, and showed a little bit of benefit in everybody unselected, compared again to best supportive care, placebo-controlled trials in the second-line setting. And when patients ask me, okay, tell me about this clinical trial. I don't want a sugar pill. I don't want to be a guinea pig. Like, we actually had sugar pill clinical trials. And I always say now, we wouldn't do that. We have so many effective treatments. We want to give active treatments, right? But here were old placebo-controlled trials, not that long ago. So then one of the biggest things that came along after this was bevacizumab. So this is an anti-angiogenesis therapy. It was a monoclonal antibody, so a protein that was made to bind to a molecule floating around in all of our blood that tells blood vessels you should grow. And some tumors, although even now, a decade later, a little more than a decade later, we haven't identified which tumors have those signals really high and are most sensitive and which tumors aren't. So bevacizumab, when I think about the relative potency of all these treatments, I think of the platinum is most of it. The second drug that's added into the platinum is other drug. And then the bevacizumab adds a little bit, but it adds a little bit of side effect too. So we don't commonly use it in everybody, even though it's an FDA-approved drug. Pemetrexed, another second-line chemotherapy, or also known as Alimta, is actually highly tolerable and one of the newer chemotherapies that was one of the first drugs used in lung cancer that could be continued for more than 3 or 4 months. So all of these drugs, except for erlotinib, generally you would give them for a few months, but then the side effects got so bad that we would stop. And then when the cancer started growing again, we changed to something else. But pemetrexed is a drug that's tolerable enough that we've had patients who get it for many years. If it works, continue it on, and it's not so bad. Then there were a number of trials to say, well, if second-line treatment works, why are we waiting? Why don't we give first-line treatment, and then we'll move straight into something new for second-line treatment? So maintenance trials and switch maintenance trials became the trial designs here. And it settled down to basically, we will maintain pemetrexed, but nobody, patients or doctors, aren't really excited about, if you're on a treatment that's working and you know your side effects, switching to something new just because you're getting something new. Nobody really likes that much. So the switch maintenance strategy has never gotten very popular. And then, so pemetrexed got a refine to it only works in the non-squamous type. Bevacizumab worked in non-squamous. Ramucirumab, we use a little bit. It's sort of like an improved version of bevacizumab. It's another antibody, but we're not using that much of it. And then a drug called necitumumab, which is for squamous lung cancer. At Stanford, we don't see very many patients with squamous lung cancer, but necitumumab is a fairly tough treatment that's out there and one of the newer treatment options potentially, although we use very, very little. So that's kind of the chemo and targeted therapy. And then my 3 pillars, I was trying to make a watermark of like the 3 types of Greek columns, and it just kind of looks like garbage on the slide. Sorry about that. But it looked a little nicer on my screen. But it was like Ionic, Doric, and Corinthian, right? The 3 classic columns. But the first column is chemotherapy. And here's the platinums and the number of other drugs that are all effective, and many have different mechanisms of action. So then, we used to treat lung cancer as all one disease, but it's not really. It's many different diseases and many different subtypes and many different etiologies. And if you divide it into just simply adeno or squamous type of lung cancer, and then do molecular analysis, which we routinely do on adenos, but we don't do very much on squamous, we find that there's actually a lot of different gene mutations. And these are non-overlapping. So tumors don't have to have one, but the ones that have one tend not to have multiple of these at the same time because they're called driver mutations. And I like to think of these as kind of a circuit that's signaling inside the cell. And normally it's sitting on the outside of the cell and it's flipping on and it's flipping off in response to signals, switch on, switch off. And these mutations on the gene level actually stick that switch in the on position. So they just fix it in the on. So the normal signal can be there or not, but it doesn't matter because the signal's on, and it says grow, grow, grow. And it also tells a cell don't die, because cells that are growing uncontrollably actually die uncontrollably also. So it shifts that balance just a little bit. But I think of cancer not as like growing uncontrollably in lung cancer. I think of it as it's just a little shift in the balance between growing and dying cells. And cells are dying all the time. We like when cancer cells are dying, right? We like that. So it's just a little change in the balance, but the net is over time, cells accumulate. And that's where the problem comes from. And these are the driver mutations that can give rise to those. EGFR is one that is very, very common. ALK, HER2, all of these. KRAS is a big driver, but we haven't found a target for it yet. In squamous lung cancer, many of these alterations are identified. They've been found, but there's not really good ways to give pills or targeted therapy to inhibit these trials. So we're doing this more for research and testing of squamous lung cancer. But in adenocarcinoma, it's standard of care at Stanford to look off the bat for all newly diagnosed adenocarcinomas at EGFR, ALK, ROS1, because those have first-line treatment decision implications. And then we do a 200-gene panel to look for kind of everything else, of which a few of these genes are important. So how do we target these things? Well, there's a few different strategies. So one of the strategies is these are the switches. These are the receptors on the outside of the cell. We call them tyrosine kinase receptors. How are we doing on time, by the way?
Good.
Okay. All right. So So these are the tyrosine kinase receptors and blocking antibodies and ligand blocking antibodies. So for example, the anti-angiogenesis blood vessel drug bevacizumab Avastin works like this. Tarceva drugs work like this. They get in there and inhibit the switch. And then receptor blocking antibodies, ramucirumab or that necitumumab drug would be examples of this, where they just bind to the protein directly on the surface. So there's different ways that these proteins can be targeted to shut them off. So the targeted treatments of non-small cell lung cancer, here's kind of the same slide with the milestones of what do we have in targeted therapy. Well, interestingly, so EGFR mutations were described right at the same time that erlotinib got approved in all lung cancer. But then it wasn't until about 5 years later that everybody accepted. A few people were saying EGFR mutations really matter in these years. And I was at a place in training where they were called mutationists because they said the mutation is the most important thing. But other institutions said, nope, it's the protein expression, or nope, it's the gene level, or like other tests are the predictor. But really, erlotinib and EGFR mutations were found to be the most important predictor of tumor response to the drugs erlotinib and its cousins, EGFR inhibitor. At the same time, ALK rearrangements were described, and shortly after that, only a couple of years, crizotinib was approved for ALK-positive lung cancer, only about 4 years after they were described, and about 5 years after EGFR mutant cancers were described, erlotinib came out here. Few other drugs have come since for both ALK and EGFR mutant lung cancer, including an EGFR afatinib and gefetinib, all approved. And erlotinib's FDA approval, interestingly, a few months ago, was actually restricted back to only EGFR mutant lung cancer. So that old effect in kind of unselected lung cancer that was believed to happen, the FDA took a look at all the data and a little bit new data and said, we don't really believe it anymore. We think that it was the EGFR mutant patients in that trial that probably that had the survival benefit. So crizotinib was approved for ALK and for ROS1 also, which is another one of these switches that can be turned on genetically. And then one of the more interesting things that we'll touch on is osimertinib, which got approved for a resistant form of EGFR mutant lung cancer, because half of lung cancers became resistant in one way when they had EGFR mutations. So let's talk a little bit about resistance. It's great when the tumor is shrinking, but oftentimes these tumors start where they start, they shrink down, but they're still visible for a while. They kind of stay like that, and then they show hints of growth. And when they show hints of growth, oftentimes the genetics have changed about the tumor slightly. That's how they've gotten around and become resistant. And there's different ways for them to do that. So the sensitive switch, these are the switches, can be inhibited by the little triangle pills, and these are the downstream signaling pathways grow and don't die. They can be mutated so that that drug no longer binds. The target can be mutated, and then the drug can't bind anymore, and then it's still turned on. So that happens in a predictable way in about half of EGFR mutant lung cancers, and in multiple ways in ALK-positive non-small cell lung cancer. Also, you can just have the target here, and you can just make a lot more of them so that there's not enough drug to bind anymore. And it seems like you should be able to give more drug, but if you get enough protein out there, it's just kind of getting active regardless of the amount of drug that's around. So you can have just more proteins. And then finally, another system that cells can use is to have other switches. So basically, you just bypass the circuit entirely and have another switch turned on that's totally different and doesn't care about whether the primary switch was on or not. So it's basically the circuitry changed and just went around. So we observe all of these when we take patients who have been on pill therapies and their tumor is growing a little bit, and we take a biopsy. That's why we sometimes offer repeat biopsies and encourage them even. And we find what's going on and how can we try to target it next. And chemo works on all of these because chemo just affects dividing cells, but sometimes we can be smarter and say, let's target that form of resistance. This was a T790M resistance. So this is the protein, this is the crystal structure of the switch, of the EGFR, with a T790M, that little orange residue in there, and they crystallized it and said, look, Tarceva just doesn't bind to this. That's not why it's not working. And this was described back in 2005. But it took 10 years to find a drug that would actually bind when that mutation was there. And that drug's osimertinib, which got approved a couple of years ago. So here's the list of drugs that are targeted. So here's the angiogenesis drugs, which we use a little bit, but not a ton. Here's the EGFR drugs. So we have erlotinib, afatinib, gefitinib, all first line. Osimertinib, that's for that special T790M resistance that happens in about half of tumors. And necitumumab, which is in this category, but different for squamous. Actually, there's trials ongoing trying to combine like this EGFR inhibitor and these EGFR inhibitors because they may have synergistic activity. There's some evidence of that. So we're working on those trials and getting them running. ALK and ROS drugs, there's crizotinib, and then when that stops working, ceritinib, alectinib, and soon to be brigatinib will probably join this list of drugs that work after the first ALK inhibitor doesn't work. So lots of targeted options, as well as many other mutations, which we can target with various strategies. A few of these strategies are more effective than other strategies. And this is an area of active research because many of these alterations are either less sensitive to targeted therapies or that their frequency is so low that even though lung cancer is common, each individual mutation frequency, we don't have that many patients to be able to say, okay, now we can enroll 200 people and see whether this is really good. So we have various therapies for various uncommon types of mutations here. And these are still more experimental. Now immunotherapy. Everybody's here because they want to hear about immunotherapy, right? Yeah. And so immunotherapy, here's the simplest complicated drawing that I could find. We can make these much more complicated, trying to throw all the proteins on there and everything else. But if we really distill this down to the element, I like to view this as the simplest components are, here's the tumor cell, and here's a T cell. The T cells are the effectors. They're the active going in and fighting specifically that there's a problem in a cell types of cells. There's dendritic cells and other guys too that are presenting what's right and what's wrong and trying to educate all of these guys. But let's focus on the tumor cell and the T cell. So if a tumor cell starts growing uncontrolled in a body, sometimes it irritates the immune system. And the immune system says, okay, there's something abnormal there and starts coming in and trying to fight it. And maybe, we don't know, maybe sometimes the immune system is completely successful before we even see a cancer and the cancer's gone, right? For all we know, you can't prove it, but that could happen for 9 out of 10 cancers, and we only see 1 out of 10. But in some cancers, they evolve a way to defend themselves against the immune system. And I like to view that as a shield. And it's the PD-L1 that seems to be a very important shield protein. This is kind of a stop signal. I like to think of it as a stop sign that the tumor is putting up there. So the immune system comes in and then it sees the stop sign. The immune system's not mutated or altered, so it has to respect that normal signal and just says, okay, stop. There's nothing to see here, nothing to fight here. But we know that this is important only because we found drugs that work against it. There are many other potential signals that tumors could use to evade the immune system, but this one seems to work and happen in about 25% of lung cancers. And in about a quarter of lung cancers, inhibiting this by giving antibodies that stick to either the PD-L1 and kind of spray paint that stop sign, or spray paint the eyes on the police officer who's trying to look at the stop sign on the other side. Those antibodies work on either side of this signal, so it's pretty clear that there is an effect and can help the immune system fight the tumor again and shrink the tumor. These drugs don't work forever either, and there's resistance that happens, and that's much less understood than the resistance, the genetic resistance to targeted therapies. But that's one of the active areas of research that we're trying to get into is saying, when the immune system starts fighting it, but then the tumor fights back, what's going on there? And also, why don't most tumors respond to these? And can we teach the immune system to respond to the tumor for those immune systems that are just kind of ignoring the tumor in the first place? So this is a very interesting interaction, and we only know that it's important because we have drugs that it works on. For every type of interaction that we see here, there's many that were tested and inhibitors that just didn't work. So many clinical trials, but a few did. And PD-L1, the shield protein, we test for this routinely in the first-line diagnosis of lung cancer now, because for patients with very high expression on their tumors of PD-L1, there's actually data to say that giving an immunotherapy drug alone is statistically more effective than giving chemotherapy in the first-line setting now. And this is, to me, one of the most exciting things that's happened, because now we've displaced for a few patients. We've displaced chemotherapy from the first-line setting and said it can be second. For patients with EGFR, ALK, and ROS, we're doing that with pill therapies. And now for a different group of patients with high PD-L1 expression, high shield protein expression, but not 100% respond. And of the tumors with no shield expression, some still respond. So there's still a lot of work to do to figure out why do some tumors not respond even if the shield's high, and why do some tumors respond even if they don't appear to have a shield? And we're trying to figure that out now, because it'd be best to have a really strong predictor. So here's the milestones in immunotherapy, and they're all in the last couple of years here. But there were lots and lots of vaccine and immunotherapy clinical trials that have been done over the last 30 or 40 years. Many, many different strategies. And I always wonder, did these not work? Not because they weren't a good idea or they weren't the right thing, but just because the tumor had the shield, and would these have been better had we unmasked the shield protein at the same time as trying all of them? So now a lot of the strategies are giving these drugs that work in combination with other drugs that may even further stimulate the immune system. So here's my lousy pillar over here, but we have 3 drugs, and we're looking at potentially a longer list, I think, over the next few years as time goes on. So this is really the major focus of research right now, as well as some of those other targeted therapies. So here's the whole thing all put together. Pretty busy slide, lots of different things, but breaking it down by color, we can see that there's a few different groups. And the amazing thing about having multiple different types of treatment that work on a tumor is, if the tumor becomes resistant to one type of treatment, switching to a slightly nuanced form of that treatment, that's okay, but the tumor probably can get resistant again. But if you switch completely over to chemotherapy and completely over to immune therapy, we've seen that sometimes if you go back to the original thing, the tumor will have so many pressures that it can kind of forget why it was resistant originally, and you can kind of keep rotating through these different treatments. We generally don't recommend giving them all at the same time because, as many people in this room know, these treatments are not without side effects. And we don't have to dwell on the side effects. But if you give 4 or 5 or 6 drugs at the same time, it's going to have all of the side effects of that. And by spreading them out over time, I believe that the effectiveness is the same, but the side effects clearly are a lot less because they're not all together. So here's the full list of drugs that are approved now. And here's what I see as kind of the future of non-small cell lung cancer. These are the new things that we've just talked about, but what are the newer than new? Well, we need to improve the efficacy and the tolerability of the treatments that we have. And we do that through supportive medications. When people got cisplatin in the 80s, they would throw up on the way to see their oncologist before the second dose because they remembered how bad it was. It was like that Mexican restaurant you can't go back to. So people aren't doing that anymore, and it's all because of other drugs. The cisplatin is exactly the same, but we can cover up nausea and vomiting now, which is amazing. Predicting responses earlier in treatment, we wait 6 or 8 weeks, but ideally we would not have somebody on a completely ineffective treatment for very long. We try to predict as much as we can, but in reality, we have to try it and see how it goes. And if it works, we usually look at 6 weeks, 8 weeks, 12 weeks, and see if it's shrinking the tumor or at least keeping it stable, and we consider that good. And if it's growing, we consider it bad. But it'd be nice to have tests to know that sooner so that patients can try everything that might potentially be effective instead of having to say a lot of time investment in a treatment that's not working. New options to overcome acquired resistance for targeted therapy. So these are those switch mutations. And we're getting smarter about detecting those switch mutations and thinking about combinations of drugs that might overcome those mutations in the signaling pathways. So lots of work in this area. Then we have combination immunotherapy. Certainly this is a very exciting field because one drug by itself probably isn't going to work indefinitely. There's a few patients who have been on immunotherapy for more than 5 years. We hear about them. But most people, it's a transient response, and then the tumors become resistant. There's also a few patients who have been on targeted therapies like erlotinib for more than a decade. And so there are some tumors that are amazingly sensitive, but by combining things, I think we hope to not have more toxicity, but also see longer responses. Maybe we'll get to that expectation of long-term disease control instead of it happens sometimes and we don't know why. Genetically engineered cellular therapies. I hesitate to even put this on here, but it's almost, it's a little bit of a like pie in the sky dream. Can we take somebody's immune system cells out and teach them how to fight the cancer and put them back in? You might have heard they're doing this in childhood lymphomas, the CAR T cell therapies. And we're doing kind of a CAR T cell light type of clinical trial. We're screening people right now. The problem is it's really hard to find people with the right immune system and the right tumor protein that can be targeted. So our estimate is maybe 1 in 20 patients might be eligible by current technology. But I can envision a world not that long from now that we're kind of taking the T cells and engineering and customizing them and putting them back in, which should be a more specific type of treatment. The problem is that lung cancer cells and your body cells share a lot of similar proteins, and you don't want to eliminate the proteins completely. In those childhood leukemias, you don't need CD19 anywhere in your body. You can live without it. So you can say, destroy all CD19 and eliminate it from the tumor and everywhere else, and people are okay. But the proteins on lung cancer cells are really shared. And so we can't eliminate all of those proteins. We can just try to fight them. And then, of course, identifying earlier stage disease. Because, we can treat and we can manage stage 4 lung cancer, and we will always need better treatments for stage 4 lung cancer. But we'd like to eliminate the diagnosis completely. Like, that's obviously the best thing. And reducing smoking is good, but there's still never smokers who develop lung cancer, many never smokers. And so it's going to happen regardless. How can we find it and how can we treat it earlier? Like they have in breast cancer, for example.
First, how can you find cancer clinical trials at Stanford? You can visit the cancer.stanford.edu/trials website and conduct keyword searches and browse conditions and eligibility flowcharts. You can download the Stanford Cancer Clinical Trials Search app, which is available for free in iTunes and Google Play. And you can contact the Stanford Cancer Clinical Trials Information Service. And we also have in the back a handout on how to find cancer clinical trials at Stanford. Now, for studies available at other institutions, you can find information from the National Institutes of Health at clinicaltrials.gov, the National Cancer Institute at cancer.gov, and the American Society of Clinical Oncology at cancer.net. And if you have a general inquiry about cancer clinical trials available at Stanford, an information specialist can help you identify trials available, provide you with a study contact for the clinical trial, provide you with a new patient coordinator contact, explain what to expect if you would like to enroll in a study, and send you information related to your inquiry via email or postal mail. And for assistance with general resources for your cancer information search, we would like to suggest the Stanford Health Library, where you can get help from a health librarian at 4 locations. They provide free customized literature searches for your medical or health-related questions. And you can contact them via the web, too, to request information. Also, the National Cancer Institute has a cancer information specialist who can help you with a variety of your cancer-related questions, including assisting with clinical trial searches. Services are free and anonymous. And lastly, cancer.net provides comprehensive oncologist-approved information from the American Society of Clinical Oncology. Also, if you're interested in future events, you can contact our website and subscribe to our email list. You can subscribe online at cancer.stanford.edu/trials. And on the website, you look for subscribe to our events, which is underneath need help finding a trial. Begin the question and answer portion of the talk. I already have a few from the webinar people, so I'm going to read that. And this
Did
is...
anybody here log into the webinar just to ask questions?
Well, we're not going to know.
All right.
Yeah.
With iPhones, you can do that. All right.
Okay,
what do
so
we
that's the first one. I have small cell carcinoma of the uterus, poorly differentiated. I'm told it's treated similarly to small cell lung cancer. What are the best protocols and new treatment options for this? I'm on day 1 carbo and VP16, day 2 and 3 VP16.
So, yeah, we can answer specific treatment questions, but in general, we're trying to paint broad strokes and help people get connected with the right resources. So, I agree with the statement that small cell carcinoma of the uterus is generally treated similarly to small cell lung cancer. there's less known about small cell cancers of other origins, but small cell cancer can show up anywhere in the body. Small cell cancer of the lung just happens to be the most common. So these treatments that are said carboplatin and VP16, VP16 is known as etoposide also, and those are very reasonable treatments. In terms of protocols and treatment options, if this person's getting treatment here at Stanford, probably through the Gyn-Onc group because of the primary, the treatment provider is welcome to email me and check in if there's any specific things. I generally recommend every patient can be their own advocate, but everybody who has a treating physician, whether it's somebody at Stanford or somebody outside, I get emails continuously from outside oncologists saying, here's my patient and here's the strategy, and do you have any clinical trials right now? And we can figure it out pretty quickly. So I encourage doctor-to-doctor communications that can really be efficient. So that's what I would encourage.
Thank you. Here's the next question. I had a stage 1B non-small cell adenocarcinoma that was removed through lobectomy. What therapies are available if my lung cancer recurs later? For a non-calcified ground glass lung nodule, what treatment is best if it turns out to be another primary lung cancer or primarily lung cancer?
So, it depends, right? So, the glass half full perspective is a stage 1B non-small cell lung cancer that was removed with a lobectomy. We described that. And there's a really good chance that that's the treatment that will cure it. And for this stage, there's rarely an indication for chemotherapy. Ground glass nodules and things like that they can be cancer, but they tend to be very slowly growing. And we put them in almost a different treatment category completely. So I like to say to our patients who have had treatment, there is no cancer until somebody tells you otherwise. How can you live any other way? We can't live right now in this room wondering if there's going to be an earthquake in 5 minutes, right? Or now suddenly everybody's worried, right? But that's the kind of worry that people can live with once they have a cancer out, which is interesting because so many people live with cancer and can kind of figure out the psychology of it. So keep getting surveillance, again, doctor to communication if things aren't going well. But hopefully needs no treatment.
Okay, another one. What's the progress for stage 4 non-small cell lung cancer adenocarcinoma with chemotherapy plus targeted therapy?
What's the prognosis for stage 4 lung cancer adenocarcinoma with chemotherapy and targeted therapy? This is a question that I will evade in clinic on a one-to-one basis, right? So it's even with all of the information. I alluded to this. What we have prognosis, what are the meaningful units, first of all? And I'm not talking days or weeks or months or years. I'm talking about meaningful units of quality of life. What are the goals? What do you want to do? What are those aspirations, and what do you need time to do? So, and how do you navigate, regardless of the treatment and the side effects, how do you navigate to do those things that are most important? So for people with stage 4 lung cancer, I say, you got to focus first on quality of life. And if your quality of life is good, quantity will follow. It's how we live life anyway, right? Even without cancer, is most of the choices, even people who don't like to work, they work because they'll have fun with the money that they get from working. So it's still about quality of life, even if they're working even if they don't want to. So it's highly variable. And some patients respond really well to many therapies. Some patients, surprisingly, their tumors are really resistant to therapies off the bat, and it's so frustrating. I'm happy to talk to this patient, if they don't have a Stanford provider, but I can't specifically say. It's a wide range depending on treatment responses. But I like to say the prognosis, you can live with a stage 4 lung cancer indefinitely. That's what I like to say.
Okay, next one.
I can read it if you want.
Okay.
Do I think certain viruses such as EBV can cause some lung cancers? That's question 1. And question 2 is, do I think that chemo dosage may be a little overdosage if the patient is Asian? So let's go with 1. I think so EBV viruses can absolutely be associated with lymphomas and hematologic malignancies. And HPV can be associated with head and neck cancers and cervical cancers. And hepatitis B virus has a strong causative in hepatocellular carcinoma. So in general, absolutely viruses cause cancers in some very clear patterns. I think for lung cancer, just like we don't know, which cosmic ray or which cigarette or which moment that first mutation that really started the spiral of events happened, I think it's hard to say whether EBV is associated. Certainly we don't test for it. So I don't know of any evidence off the top of my head about EBV and lung cancer, but it's possible there's some viruses or something. Second, chemo dosage regarding, we'll just say ethnicity and size and everything else. So pill therapies, chemotherapies, immune therapies, we dose them based on what we think is about right. And sometimes we'll adjust to patient's body size. For pill therapies, we actually don't, because people's livers are so variable that some livers can metabolize drugs 3 times faster than other people's livers. And for chemotherapy, it's kind of the same thing. We measure height and weight and kind of adjust and say, here's about as much as we would approximate. But if there's too many side effects, we reduce the dose and we say, we guessed, but our guess was a little bit wrong. And I think regardless of whether somebody's Asian or a specific ethnicity, if side effects are really high, that's what we do, is say, how bad are they for you? Are they intolerable? And we reduce the dose. And patients are resistant to reducing the dose. But often it's because your body just didn't metabolize it like somebody else would have. Some people can drink a little bit of alcohol and feel a lot, and some people can drink a lot of alcohol and feel nothing, right? And it's kind of the same thing for drugs, where one dose is not the right dose. Good questions. Keep them coming. Oh boy, yeah. What are your thoughts on ctDNA or cfDNA screening for lung cancer? So, we didn't even talk about that, and that's a really interesting, we're new treatments for lung cancer, but a lot of the molecular technologies that have been developed are quite useful in diagnosis and monitoring and surveillance. And so this question, circulating tumor DNA, basically, I mentioned that tumor cells grow, but they also die too. And when those tumor cells are dying and turning over, that DNA just kind of gets shed off into the blood and it starts floating around. And it's possible to identify the tumor DNA, not because it says on the label, I'm tumor DNA, but because it has the same mutations that the cancer did. And those shouldn't be anywhere else in somebody's body. Those are unique to the cancer. That's one thing I didn't mention about the gene mutations. They're not heritable, with very rare exception. These are unique to the cancer. They're a mutation only in the cancer, not in the rest of the body. So those are those things. When we find DNA floating around and the DNA has a mutation that looks like a cancer mutation, we can see it. It's called circulating tumor DNA or circulating free DNA. There are companies with tests. We've developed a test here at Stanford that's on the research side only, that some people have given us lots of blood that we put in a freezer and look at periodically to answer research questions. For screening for lung cancer, I think it's complicated. So the lung cancer screening trial with people with small nodules, there was blood. I don't think it's been tested for circulating tumor DNA as far as I know. But the problem is the really small cancers don't secrete very much circulating tumor DNA. So if you want to find a 1 centimeter cancer, it's probably not making very much. And a larger cancer, a stage 4 cancer, is making a fair amount. So it's going to be tough for screening, but it's a really important question. I think there's applications for screening, for routine, like early detection of what's the mutation. We can sometimes beat the regular mutation testing with a blood test. And also maybe for surveillance, but we're not routinely doing it like we do with CT scans. But one day we may do DNA tests and CT scans together. Are there any efforts to study the failed immunotherapies to mine for molecular insights? Absolutely. So for the patients that respond to immune therapies, we would like to know, why did it work, but why did it stop working, just like targeted therapies? It's much more complicated to answer those questions, though, because the technologies, DNA is fixed. DNA is kind of the same, and it's really easy to detect, whereas these proteins that come and go on the outside of lung cancers, the shield protein, for example, which I described, the PD-L1, I sometimes use the analogy. Saying it's high or low or medium is a little bit like saying, is somebody tan or not? It depends on how you look, when you look, and what your reference is for comparison, right? So it's kind of this dynamic protein that changes. It's not a DNA thing that's fixed over time and can't change. So there's definitely efforts to study why, but I think it's a complicated set of mechanisms.
I think it's similar to screening.
Okay. I had a father and older brother get lung cancer and pass away last year. I'm sorry. And what's the percentage that I have a gene mutation in cancer? So most of the time, lung cancers are not heritable. There's a few types that are. For these questions, when a patient asks me, I say, I'm actually not an expert in this field of family genetics, but we have genetic counselors who can answer that question. So the appropriate person to see would be see a genetic counselor, elucidate the pattern, see if any molecular information was done, because sometimes we do so much gene testing for lung cancer, we happen to find things that could be heritable in those cancers, but we're not looking for heritable things. But so genetic counseling in general is the person to answer that question. And then what test would I suggest to run in order to get early detection? Again, genetic counselors are all about screening and figuring out risk. So it's an indirect answer, but it's a guide. Pretty direct questions here. All right. What are my thoughts on screening by circulating tumor DNA in the future? Yeah, circulating tumor DNA. So screening for early stage, we should try it together with CT scans and other things. But I'll give you a little bit of a scary fact. I don't like scary facts. I like nice facts. But when we got our circulating tumor DNA stuff running here, way back when people weren't sure if you could even detect it or not, it's like looking for a needle in a haystack. But it's like looking for a slightly different colored piece of hay in a haystack is what it's like. So when we got it running, we actually found that a lot of our normal volunteers had P53 mutations, which are one of the most common mutations in cancer. And so many people had those that we basically had to filter out a certain kind of P53 mutation, which is common in cancer, but also might be just from kind of sun damage or life in general or who knows what. So this whole concept of, do we have a lot of precancers kind of lurking around? Scary fact, right? But that may limit screening and detection. When we do cancer sequencing, do we look for single gene mutations one at a time, or do we do a panel to look for a wider possibility of mutations? Our current strategy is, so I want to know for a newly diagnosed patient, I want to know what's my first line therapy, right? Like as fast as possible. So I want to know EGFR, I want to know ALK, and I want to know ROS1. Those are the three we changed the first line targeted therapies for today. Might change in a year. And we can do those tests all within about a week and off the tumor. And the EGFR test, if we do a blood, sometimes we'll even get a little faster. And then we want to know PD-L1 status, the shield status, because some patients with really high tumor expression of that can get the immune therapy first. And we can do that within a week. So we do all that stuff fast. And then we have the 200 gene panel that takes about a month to do. So we have the fast initial treatment, and then we have the what's next for later. All right. How many more do we have? All right.
That's coming from the webinar, by the way.
I think we have more questions than attendees. All right. Do metastases have the same genetic profile as the primary tumor? The simple answer is, in lung cancer, almost exclusively yes. So we think about the metastases. So there's another scary concept. It's called tumor heterogeneity, and it basically means that every tumor cell is slightly different genetically than every other tumor cell. So when you're treating, that's why resistance happens, is because there's a few outliers and they happen to be resistant, and then you can treat the majority, but the few outliers are a little different already. But the core mutations, these drivers that we talk about, have the same mutation because they were in the original tumor cell that gave rise to the cluster that gave rise to the metastases. And so when we talk about a driver, those drivers are in everything until we give a targeted treatment, and then sometimes they start varying. But if we say, do they have exactly, if you biopsy different parts of a lung cancer and you do full exome sequencing, you will see differences because they're just kind of genetic variations in the cancer. I think that answers it. Do they have the same genetic profile for the mutations that matter? Are there targeted or immunotherapies for small cell carcinoma, and are they the same therapies as for non-small cell carcinoma? I'm sorry I didn't focus specifically on small cell. I focused mostly on non-small cell, but there's a couple of small cell questions, which is great. The small cell development, so it's many of the drugs that we talked about. There's platinum plus second drug, often etoposide, is first line treatment. Then there's topotecan, which is the approved second line treatment. And then many clinical trials really haven't shown benefit of other things in a widespread scale. But some immunotherapy, so there's pembrolizumab or Keytruda, has shown some effect in small cell cancers. And nivolumab or Opdivo, same thing, has shown some effect in small cell cancers. And they have a little bit more modest effect probably than in non-small cell lung cancer, but we use them, and they're in some of the guidelines even without FDA approval because there's enough data that they can potentially be effective. So many of the therapies do cross over, and Opdivo or nivolumab and Keytruda both have some evidence. More? Yes. They keep coming. All right, questions. Thinking of more questions. Do CT scans cause lung cancer? So this is a tough one, but I get it a lot in clinic because we do a lot of CT scans. We really want to know what's going on with the cancer. And so I think it's possible theoretically. All the data that we have on whether CTs cause cancer are basically extrapolated from Hiroshima data and extrapolated from Chernobyl data of like people with high radiation exposures, and they sort of follow down and say, here's the dose. So here's like living 30 miles from Chernobyl, and here's a CT scan, right? But if you have this risk here, then you kind of extrapolate it down. CT scans, we're making lower and lower dose. So compared to 5 years ago, our detectors on this are much more sensitive. So we need a lot less radiation, and our computers are more powerful. So we can reconstruct with a lot less information. So we're using a fifth of the dose of what we used a few years ago. So I think the CTs that we worry about are the ones that are done in childhood or young adolescence, that then there's a long period of time that goes by. So we really try not to, if somebody goes to the emergency department, do a CT on young people. But for people who have an established diagnosis of cancer, I think you need a long time interval for these very, very small doses of radiation in order to think that there might be a risk of causing a new cancer. I've very rarely had somebody develop a second cancer while getting treatment for a short time or a long time with lung cancer. So we're not seeing much. It's a long-winded answer, but it's a common concern. Are there any monitoring tests for lung cancer once you've been diagnosed? Once my non-small cell lung cancer adenocarcinoma and tumors are stabilized or dead, is there a blood test that can be used in years to come back and see if the cancer has come back, or an alternative to avoid CT scans? So first, I hope nobody wants to avoid CT scans after the last answer. I think CT scans are pretty benign overall in terms of risk, very, very low risk. And then, so the blood test, that comes back to the circulating tumor DNA. This kind of depends on whether it was an early stage cancer that we think is gone, or whether it's a metastatic cancer that we think is controlled. Because for stage 4 lung cancer, the goal is control. I like to offer the word when we have really good control that it's dormant. It's not growing. It's kind of quiet. It's there. We're keeping an eye on it. But you're not going to turn your back on the dormant volcano. That's why we're doing CT scans, right? It's dormant, but we're keeping an eye on it. So circulating tumor DNA is very highly experimental. We're thinking about it in the earlier stage setting to detect recurrence. This is done routinely in colon cancer with a blood test for protein markers, CEAs, but we don't usually follow protein markers in lung cancer. So nothing standard right now, and nothing that I would say don't do a CT scan and use this instead. We got more.
The last one.
All right. You're cutting off the web. All right. It's 5:30. It's a mechanic.
It's 5:30.
Yeah. What are the active clinical trials at Stanford that are studying targeted or immunotherapy? Well, what a great question. So, all the resources that we went through. I don't know, is this a web person or somebody here that we can get something?
Actually, we have.
Or did you plant this, Ellen? You planted this is the last question. So all of our resources, our Stanford flowcharts of algorithms, we're in charge of figuring out who's right for which clinical trial. It's increasingly difficult to figure out what the right clinical trial is for the right patient because we have so many treatment options that to offer a clinical trial, I have to say, here's the standard option. And here's a clinical trial that might be better or might be more experimental for whatever reason. But whenever we think about a clinical trial, we always have a standard option too to compare it to, right? And kind of the choice between those options. So knowing exactly what the clinical trial that would be right is hard to know just offhand. For the targeted therapies, it depends on the target in the lung cancer, as we went through. And for the immunotherapies, it depends on whether somebody's received the standard ones or not. But our phase 1 group, Shivani Kumar, is running a bunch of combination immune therapy clinical trials now that work across many different tumor types. And sometimes we'll refer our patients to consider one of those trials when the more standard therapies haven't worked.
And I guess that's it. Thank you so much, Dr. Neal, and everyone for being here.
Great to have such a friendly crowd.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.